Good morning, good afternoon to all of you, and thank you for having me. I'm going to start just by tandeming on one of the questions that was actually raised during the EHA section, and that is I have MGUS, but I have multiple symptoms that aren't explained. And I think it's really important when a patient with MGUS has a number of symptoms that are escaping detection, that light chain amyloidosis not be forgotten. Over the years, I've seen many patients who were incorrectly labeled as smoldering multiple myeloma or MGUS as their amyloidosis progressed, and they became more and more symptomatic because their physicians were monitoring them for the development of Crab criteria or a myeloma defining event, which is not part of the natural history of amyloid. And it's quite easy to misdiagnose an amyloid patient as MGUS. So whomever wrote in about MGUS with symptoms, this idea about being seen in a specialty unit where there's a lot of experience with monoclonal gammopathy of clinical significance, and I'm really emphasizing amyloid, would be very important. With regard to ASCO, during my 15 minutes, there are actually three themes that I personally want to cover. The first theme has to do with the fact that once a medication is introduced, we may not always know the optimal way to administer the medication. And prior examples include thalidomide. When thalidomide was first introduced, doses as high as 800 milligrams were used, and it became clear over time that highly effective intervention could occur with doses of 50 to 100 milligrams. When we started using Revlimid, lenalidomide, 25 milligrams is standard, but quite frankly, there are many patients, depending on the side effect profile, who can do very well for a long time with Revlimid, lenalidomide at doses of 15, 10, 5 milligrams, even 5 milligrams every other day. Velcade or bortezomib also started out being given intravenously twice a week. And then it became clear that you could get equal efficacy with much lower side effect profile by giving it once a week and by an injection under the skin rather than intravenous. And that's kind of the introduction to the discussion of ASCO, which were new trials on the anti-myeloma agent Selinexor, whose trade name is Expovio. Selinexor or Expovio is an oral medication whose mechanism of action is completely different from drugs like melphalan, Cytoxan, Velcade, Kyprolis, Revlimid, Pomalyst. But when it was introduced initially about 4 years ago, it was really a hard medication to administer because of the side effect profile, which included lots of appetite loss, nausea, weight loss, just a problematic route of administration. And so a lot of myeloma experts shied away from the use of Selinexor or Expovio. But when it was originally introduced, it was given orally twice a week in a relatively high dose. And that led to the, let's say, disenchantment of many investigators for the use of this medication. Over the last 24 months and the most recent ASCO, there were a number of abstracts on the use of oral Selinexor, but at much lower doses and only once a week. And it's been combined now, Selinexor, with other active myeloma drugs such as Revlimid, lenalidomide, or Kyprolis, carfilzomib, and pomalidomide, Pomalyst. And it was demonstrated that the rates of response using two drugs such as Revlimid dexamethasone or Kyprolis dexamethasone or Pomalyst dexamethasone, when combined with Selinexor or Expovio, that the rates of response were much higher with the addition of Expovio. But there wasn't a major increase in side effects. By reducing the dose to 80 milligrams or 60 milligrams, which is 3 or 4 tablets once a week, it was demonstrated that there were increased response rates but with a much lower problem with appetite loss, weight loss, and nausea. So once again, it demonstrates that when something is introduced, we don't always know the best way to use it. Just before I came on, it was discussed about redosing with CAR-T, that one dose may not be enough for sustained anti-myeloma effect, so that repeat dosing is being explored. And that really is another example of, we learn about and introduce these new medicines, but we don't always know everything there is. And I was rather impressed at ASCO by the reports on the combination of Xpovio at lower doses, once weekly dosing with other medications. And I find that that's a medicine that referring physicians in the community fail to think about when they're treating patients who need new lines of therapy, because the last previous treatment may not have been as effective as they might have desired. The second theme that I took away from ASCO had to do with maintenance therapy. There are now actually quite a number of trials that are looking at maintenance. Now, in the United States, the standard, I would say, for maintenance for most patients is taking Revlimid once a day in a dose of approximately 10 milligrams, 3 weeks out of 4. I'd say that's probably the default standard that we're seeing in the United States. But now there are a number of trials that are looking at 2 drug maintenance compared to 1 drug maintenance. And I think this may result in some important steps forward in long-term control of myeloma for patients in this community. Now, what those 2 drug maintenance regimens will be, I don't really know, because we saw trials that compared ixazomib, its trade name is, I don't know what the trade name of ixazomib is. Hold on. Jenny, do you remember?
Nilaro.
Okay. Oh, Nilaro. Nilaro with, thank you. Thank you, Craig. Nilaro plus Revlimid compared to Revlimid alone. There was a trial looking and ongoing of Darzalex or Daratumumab, the anti-CD38 antibody, plus Revlimid compared to Revlimid alone. And then the Italian group at EHA talked about the use of carfilzomib or Kyprolis combined with Revlimid, compared with Revlimid alone. So here we have 3 trials looking at 3 different 2 medication maintenance regimens. And we don't have final results, and we can't say with certainty that 2 will be better than 1. We have to be aware that 2 medicines are likely to have a higher side effect profile than 1 medicine. And we're now becoming increasingly aware, for example, that medicines such as Darzalex or Daratumumab impede the antibody response to COVID vaccination. And so these are not trivial issues, so we can't automatically assume that 2 medications are better than 1. But the second theme that I took from ASCO had to do with maintenance and the clinical trial attempt of comparing 2 medications with 1 medication. And one individual asked a question about, should patients always be considered for clinical trials? That is a drop-dead absolute yes. You should always be considered for a clinical trial. It'll get you in on the bottom floor of the next great advance in the treatment of myeloma. It'll mean that your disease is being monitored carefully by an expert in the field, and it will automatically prescribe what that monitoring will be. There are virtually no downsides. The third theme I wanted to talk about are the bispecific antibodies. I was really impressed with the reports on bispecific antibodies, and I want to give a little introduction. And that is that unlike chemotherapy, there's always been in the myeloma community enthusiasm to try and harness the body's immune system to kill the myeloma. One of the first ways in which this was done was by the use of allogeneic stem cell transplant, where you would take the cells from a brother or a sister and you would give them to a myeloma patient in the hope that the brother or sister's immune cells, the killer cells, the ones that recognize cancer and destroy it, will recognize the multiple myeloma and destroy it. And so allogeneic transplant, brother-sister transplant, was one of the first ways in which we tried to harness the immune system to destroy myeloma. The second method, introduced about 25 years ago, was the use of alpha interferon, a protein produced by white blood cells that modulates the immune system, and tried to use that to control patients' myeloma in a maintenance format. Then CAR-T came along. And for those of you who aren't intimately familiar with CAR-T, it takes your own white blood cells, those cells that are responsible for killing the myeloma, for killing cancer cells, for eradicating viruses or fungus, but it is an attack white cell that is designed for surveillance and protection of your body. And the goal is for it to destroy the myeloma cell. Unfortunately, in most patients, those killer white blood cells don't recognize the cancer. So in CAR-T therapy, your white blood cells are collected, but then they're modified, they're reconstructed with proteins that help those killer cells recognize the myeloma cells and redirect them directly to the myeloma cells. And so CAR-T, which has been used now for about 5-6 years and is curative in leukemia and curative in some forms of lymphoma, is now actively being explored. And then there is one approved CAR-T treatment called ide-cel, but there are about a half a dozen in research phase where those white cells are removed, reconstructed, shipped back, and then used to kill the myeloma cells. Complications with that, as alluded to earlier on, was that most patients need some form of chemotherapy during the month to 6 weeks while those white cells are being reconstructed. And secondly, chemotherapy has to be given so that your body does not reject those reconstructed cells, because once they've been reconstructed, your body's immune system can look at those CAR-T cells and say, oh, you don't belong to me, and will launch an attack on them and prevent them from doing the good things that they do. The next generation, and that's the theme that I want to talk about now, of treatments for myeloma, the theme are the use of these bispecifics. These are proteins that have 2 binding sites. One binding site binds your killer white cells. So it attaches to the killer white cells in your body, and the other end binds to the myeloma cells. So what this protein does is it acts as a bridge, and at one end of the bridge, it connects the killer white cell, and at the other end of the bridge, it connects it to the myeloma cells and brings them very, very close together so that the killer white cell can do its job, which is to execute and destroy the myeloma cells. There are at least a half a dozen bispecific antibodies that are currently in active research. But across the board, they seem to have a very, very high response rate in patients who've had extensive prior therapy. And it's impossible to know how long lasting these will be. But the advantage that I see for these treatments compared to CAR-T is that there's no need for you to go to a specialty center that offers CAR-T, because these antibodies are given right off the shelf and don't have to be custom constructed for you. Secondly, because they can be given off the shelf, there's no need for that chemotherapy for 4 to 6 weeks to keep things under control, to keep the lid on while construction's occurring, because there is no construction. And finally, there's no need for chemotherapy to prevent rejection of the antibodies, because those antibodies aren't living cells that trigger a major immune response. And again, I don't know which of these bispecific antibodies is going to turn out to be the best, but they're almost all in clinical trial. But they're very, very exciting because all of the reports at ASCO demonstrated that they were highly active and that the toxicity profiles were relatively low. And I envision my own best futurist guess is that bispecifics is really going to give CAR-T a run for its money because it really has quite a few advantages. And I think, Jenny, with that, I've used up my 15 minutes, and maybe we'll circle back during the question and answer session, and I'll stop my video and watch.